Before we start, our team would like to extend our thanks to the SAGES Committee for allowing us to present our work. My name is Dana McCloskey, and I will be presenting unique enteral management of complex esophageal and gastric leaks with minimally invasive percutaneous pharyngostomy tube. We have no financial disclosures. Pharyngostomy tubes are an effective, albeit infrequently utilized means for long-term enteric access. Since their first description, pharyngostomy tubes have been employed to provide prolonged gastric decompression for patients who would otherwise require long-term nasogastric tubes. In the literature, this is most commonly reported following esophagectomy. The traditional method of placement as depicted here is comparatively invasive, with the potential for life-threatening hemorrhage due to inadvertent injury to branches of the carotid artery. In an attempt to improve upon the safety of cervical pharyngostomy placement, we attempted a minimally invasive percutaneous approach through the avascular thyrohyoid membrane in cases of complex esophagogastric pathology, for which a need for long-term enteral decompression was anticipated. A retrospective chart review of patients who underwent percutaneous pharyngostomy tube placement at our institution between January 1st, 2016 and January 1st, 2019 was completed. Eligible patients included all patients aged 18 or older who underwent pharyngostomy tube placement with or without esophageal stent for management of esophageal perforation or postoperative leaks following vertical sleeve gastrectomy, esophagogastroduodenoscopy, or Roux-en-Y gastric bypass. The primary measured outcome included healing of the esophageal or proximal gastric defect. Secondary outcomes included time to return to oral intake, time to hospital discharge, and potential morbidities associated with pharyngostomy tube placement, including bleeding, skin or soft tissue infection, pneumonia, esophageal ulceration, and any additional pharyngeal complications. Pharyngostomy tube placement begins first with identification of the thyrohyoid membrane, which can be located first by identifying the thyroid notch, which in this image is labeled as A. From here, moving cephalad towards the hyoid bone, labeled as B. We usually aim to be approximately 1 centimeter superior to the thyroid notch. From this location, we then move 1 centimeter laterally from the midline to identify a safe avascular location within the thyrohyoid membrane for pharyngostomy tube placement. Here, our safe zone is depicted as letter C, which is where we make our transverse incision. Percutaneous access to the proximal esophagus within the hypopharynx is obtained with passage of an 18-gauge hollow bore needle through the incised skin under direct visualization using a Mac blade to elevate the pharynx. While maintaining the same view, a guide wire is then passed into the hypopharynx. Using a ring forceps, the guide wire is then grasped within the oropharynx and directed out of the oral cavity. Our team prefers using the percutaneous insertion kit depicted here for initial access and then subsequent tract dilation. Here's just a short video demonstrating the passage of the guide wire through the lateral skin incision and then guided out of the oral cavity under direct visualization using a Mac blade. Subsequent dilators ranging from 8 French to 16 French are placed over the guide wire to create a tract that will accommodate a 14 French or a 16 French pharyngostomy tube. Umbilical tape is then attached to the proximal end of the guide wire and passed externally through the neck incision. We then use a silk suture to create a lasso through the distal end of the pharyngostomy tube, which will then be tied to the external portion of the umbilical tape. Using the umbilical tape, the pharyngostomy tube is then guided through the dilated tract within the thyrohyoid membrane and into the hypopharynx. The pharyngostomy tube is then directed into the esophagus or stomach under direct visualization with EGD. During cases in which an esophageal stent is also placed, the final positioning of the pharyngostomy tube can be confirmed with the use of intraoperative flouroscopy that accompanies our standard protocol for esophageal stent placement. During our study period, 5 patients underwent pharyngostomy tube placement. As a tertiary care referral center, cases were complex in that they were also often associated with large abscesses or had some degree of chronicity that made these patients otherwise poor candidates for conventional surgical management. Esophageal perforation and anastomotic leak were the most frequent indications for pharyngostomy tube placement, each comprising 40% of the treatment group. In our experience, there were no cases of leak following Roux-en-Y gastric bypass that warranted pharyngostomy tube placement. 80% of esophagogastric defects healed, as demonstrated by either barium esophagram or repeat EGD. Notable outcomes include one death due to tracheoesophageal fistula in a patient suffering from an anastomotic leak following esophagectomy. This mortality occurred after inadvertent pharyngostomy tube removal and was due to esophageal stent erosion. Another patient admitted with esophageal perforation suffered from recurrent episodes of aspiration pneumonia, which we believe is not attributable to the pharyngostomy tube, but rather due to severe esophageal dysmotility as a result of her injury, which persisted even after the pharyngostomy tube was removed. The average time to pharyngostomy tube removal was 33 days, time to oral intake 43 days, and length of stay following pharyngostomy tube placement was 17 days. There were no instances of bleeding or skin or soft tissue infection associated with pharyngostomy tube placement. Based on our experience, pharyngostomy tubes may be an effective means for long-term internal decompression, particularly in cases of complex esophageal or proximal gastric pathology. Our technique for percutaneous anterolateral pharyngostomy tube placement with endoscopic guidance facilitates placement of an anterior tube, decreasing the risk of inadvertent vascular injury. Thank you all so much for your time. We are happy to take any questions you may have.